I'd like to introduce Alison now, and just as she's coming up, about 9 months ago, I was asked to chair a meeting down in London on. I was asked to chair a meeting down in London on outstanding general practice. And I thought to myself, actually, I don't want to do that because general practice is really struggling. Every GP I know is finding it very, very hard. Why would I want to go down and look at outstanding general practice and see what the CQC is doing? But I've got this thing that says, don't just listen to what Pulse says or what the Guardian says or the Daily Mail or whatever. Actually hear it from the horse's mouth. And so I decided to go down, listen to this presentation, hear what the CQC have to say, hear what the GPs that were leading this work have to say. And in the afternoon, there were a number of practices that had got outstanding. And even though I'd gone there with a very negative viewpoint, I came away coming back on the train back thinking, oh my gosh, this was just absolutely incredible. I didn't realise how much I didn't know and how much we could all benefit from doing this. So I asked the CQC if they'd done this many times before because I've never come across it. And they said, well actually no, we haven't. So I said, right, well, I'm going to come back to Manchester. It would be nice to be able to learn from the CQC and your experiences and see what we can do. So, thank you very much.
Thank you very much. Can we just introduce ourselves first? And so I'm Alison Holbourn, so I'm Deputy Chief Inspector for the North Region PMS. So it's PMS as in, not as in PMS contracts, but as in personal medical services, primary medical services, dentists and integrated care. So I'm responsible for the Northern region and I link up with Greater Manchester. I go to the Quality Board and it's been a great pleasure to sort of work with colleagues and see how that's unfolding over the last few months. Peter, do you want to introduce yourself?
You might as well mention Manchester.
Okay, go. Right, so and my colleague, we're going to split the time pretty much. We've been given 20 minutes approximately, so we'll do 10 minutes each to allow some time for questions. But I joined CQC back in September actually, so I'm quite new in regulation, but I'm not new in terms of being regulated. So I've worked in primary care, community care, and social enterprise around health for a very long time now. And in fact, I was for 8 years. I was in a local primary care system in Salford, and have had the experience, as one of the other speakers has, of achieving an outstanding rating, which made us feel like a difficult journey was actually quite worthwhile. So anyway, enough of that later. So that's my background. And Peter?
I'm Peter Davies. I'm a GP from Halifax, and in CQC terms, I'm their regional medical advisor. So for the last almost 3 years, I've been having the fun of hearing about general practices right across the country. My remit is to read reports for the north of England, which is basically Sheffield up to the Scottish border. I've read a lot of Manchester ones, Manchester area ones, but a lot of all the way across, and I've had the fascinating journey of seeing just how variable general practice is, and also, in fact, how good it is in some places as well. So I'm hoping I can give you some of that learning.
So, contact we've had before, so around, very, very interesting and inspiring to hear what John had to say here. And we actually had a really interesting meeting in December with Tracy Bell and some of the other people from the Association of LMCs to talk about what you're doing here and the new world and the changes around sustainability of general practice. And conscious that we need to really respond to that as the regulator and to be engaged and involved in the next phase of our work around new models of care. 2 or 3 weeks ago, we had a workshop to work with a lot of people involved in innovative new models of care delivery in primary care from right around England, and a number of colleagues came from Greater Manchester and talked to us very openly about their experiences, what they need to do next, what the system needs to do to transform, and that's actually going to be driving our next phase of work. But what we're just talking about now in this session is we've been asked to talk about what we do, what we have done, what we've learned, bit of a general focus around GM and what we found to date. But I'd open really by saying we've just finished in this North region for the very first time, from October 2014, all practices that were registered with us in October 2014 have been inspected and rated. This is the first time this has happened in general practice in this country, and as mentioned by the chair, it was not without its critics and controversy. However, we found some really interesting things, and many of you will have been through the process. So that's what we're going to focus on here. So what we do, very quickly, you all know what we do, but under an Act of Parliament and the Health and Social Care Act, we are the appointed independent regulator of health and adult social care in England, so we regulate the providers in the whole system, and our job is to make sure that health and social care services provide people with that safe and effective and quality care that we would all want for ourselves and our families. The document pictured there, you can find on our website. That's our 5-year strategy, Shaping the Future, and there's some interesting statistics in there which I feel we should all regard as cause for celebration around general practice in this country. So have a look if you've not seen it already. So our role is, through all of these different 4 facets really, so that for the vast majority of providers in the UK health system, it's in the English health system, we have a registration system, so that if you're a contract holder, you're required to register as a provider in the health and social care system. So once registered, we would monitor and inspect services, and we do that against a number of headings. So you will be aware, if you've been through the process, that our inspectors have key lines of inquiry. They look at data, they look at patient feedback, they look at what you tell them, the evidence that you give to them on the day of an inspection. What they're looking for is those 5 domains: whether a service is safe, whether it is effective, whether it is caring, whether it is responsive, and whether it is well led, because all of those things together are critical in delivering a quality experience for the recipient of that care. If required, we do have legal powers to take action where we do identify poor care. Thankfully, that's in a very small minority of cases, but that power is there under legislation. One of the most important things we do, finally, is we provide an independent voice. And we speak independently. We publish both regional, local and national views about the care system, and we try to encourage improvement by highlighting good practice. So recently you might have seen that we published the State of Care report, and again, if you haven't seen that, I'd encourage you to have a look at it. It's had quite a strong voice in national policy, and it has been, I think, quite useful in illuminating some of the pressures on the system, and adult social care in particular, we all know, is under a lot of pressure. And what we can say independently can bring light to that. I, on a daily basis, I sign off reports, and I sometimes have to sign off press releases, and often it's a very inspiring thing to do. I've only been here for a few months, but I get to sign off the outstanding reports and the outstanding press releases. Having worked in general practice, community care, and associated fields all of my life, public health, for example, it's very inspiring to see that, despite the pressures, that we are actually doing such a fine job. You are doing such a fine job in general practice on the 9 out of 10 contacts where you are the cornerstone of the system. So we've talked about these elements, but that is essentially what we do. That's our role. To give you an idea of the scale, with England's population of 53 million, I'll just focus on what we're here to talk about, primary medical services. So far, we have inspected and rated 9,000 providers in this tranche of work. the numbers of providers in PMS is increasing, because although individual practices will remain and will remain the cornerstone, more and more federations are registering, social enterprises, clusters. The development of general practice at scale is very much a feature, and we're trying currently to make our registration process a little bit more streamlined, because we need to make some changes there. So that's the scope. So when we've been in and we've rated a service, there's basically four ratings: outstanding, good, requires improvement, inadequate, as the definitions are stated there. And we've basically got very few on the inadequate side of things. We've got a cluster of outstanding, and we've got this in terms of what we've found so far. So last summer I was sitting in my primary care role, and I got the CQC strategy dropped into my inbox, and I flipped through it as you do, had a look, saw a graph something like this, saw the similar graph for the acute sector in hospitals, saw the social care position, and I just thought, I knew it, I absolutely knew it. Isn't it great to see it in black and white on a page? Having worked in primary care, seen the dedication of all the staff that deliver those 9 out of 10 contacts for all of this time, to have a programme of work that actually shows that 87% of GP practices inspected in this country, which is the vast majority, are providing a good or an outstanding standard of care. I'm just going to let that sink in for a moment, because we hear a lot of doom and gloom and there is a lot of challenge. Certainly from, since 2010 onwards, I felt that general practice is in one of the most precious states that I've seen it in since I started in the 80s. However, despite all of that, this is what's being achieved. So all of the stuff that John was talking about sustaining it and being really responsive to the needs of professionals and people and populations, makes absolute sense against that sort of background. So, out of interest, of the key questions that we talked about in the ratings, so whether a service is safe, effective, caring, responsive and well led, the green bars show how practices perform nationally against those particular ratings. The least easy, if you like, to achieve good and outstanding seems to be the safe domain, because the key lines of inquiry cover a huge amount of elements: the clinical, the practical, the environmental. But nevertheless, a really good score there. Caring is really interesting, because you score really well in Greater Manchester on caring, and many practices do, and that's why we're all in it, I guess, at the end of the day. So I thought you might like to just have a quick look at general findings around Greater Manchester. We shared this information, there was a lot of detail around it. We shared it with Tracy and colleagues back in December, and very happy to distribute it as the foundation conversation. We also go to the partnership quality board, and we can contribute information, data to the conversation. So these figures are based on the local authority footprints. We can cut them by CCG as required. We've got the top left-hand side is the Greater Manchester figures compared with England as a whole, and then the North West. If we look at the overall figures, there's a very slightly lower quality score if we take the aggregate right across general Greater Manchester as a whole. However, the really interesting thing, just to flash this up, is not the difference between Greater Manchester, the North West and London, but within Greater Manchester. So if we look at the Greater Manchester boroughs, and we look at the proportion with good or outstanding, and we look at the ambers and some of the reds, we can just see, we can see difference. So, there's a lot of information onto this, but in your clusters, as you're working across the partnership and working in the Association of LMCs, it's really interesting to look at this stuff and to look at the kinds of learning points that are coming through, some of which Peter will pick up on in a moment. Just before I hand over to Peter to do that, these are some genuine comments on inspection feedback and practices. And we appreciate that the inspection process has been a pressure and a stressor for many practices. However, we have had some increasingly positive feedback from practices recently about how the process has impacted on them, how it's enabled them to reflect, how the information and the feedback has perhaps helped them in a way that they perhaps didn't expect. So we have had a lot of other comments as well, which you won't be surprised to know. But it's just to give you a flavour that we are doing that. We hope that what we do is genuinely giving people information that will help sustain and improve. I talked about the state of care. General practice features in that as doing a great job for healthcare in the UK. So my last piece before handing over to Peter, the majority of practices provided a really good quality care for their patients. Where we have found issues or problems in the small number that we did, and we had to provide guidance on those practices, how to improve. The vast majority of them, 75%, if we have reason to go back within 6 months, 75% have turned it around and improved and got better. And some haven't for very particular reasons, and they are then in a process of support and improvement to try to resolve the situation in some way for the benefit of patients. As John said, the whole success of the system relies on effective primary care because you deal with 9 out of 10 of all of the contacts, and we are seeing a huge change right around the country in GP practices, working together collaboratively to try and create that sustainable position for the future. I'm not going to talk about this in detail, but the point being made, as echoing John's point, is that there's really good evidence that if there's not sufficient primary care and access to primary care, the rest of the system suffers, just as if we have pressures on social care, the rest of the system suffers and backs up. So it's really interesting to hear about how you're doing that in Greater Manchester. So as quickly as possible, we'll just give you a few learning points.
Okay, so I get fun of telling you some of the things we have learned about primary care and particularly general practice over this round of inspections. I think some of this learning, those of you who are long-term observers of the general practice scene might go and already observed some of this, but it's a bit like the diabetes care and complications trial. We all knew we should control our type 2 diabetes really well, but we were confident once we had a clinical trial to make the proof. Let's see what we've learned. What I'm going to say is that one of the key things to understand about CQC is to know what question we're answering. And the question we're answering is does this care provider work well as a clinical unit? So we're asking the question about the organisation as a whole. We're not asking questions which doctors are more, probably actually the scariest question for doctors at GMC asking about your professional competence. I think that's probably our guideline questions. We're not asking that. As CQC, we're asking, does this provider work well as a whole? And we're not interested particularly in individual doctors, or not usually anyone. What have we got? Outstanding characteristics. Outstanding characteristics really come down into 3 or 4 key points. The first is that practice will be well led or organised. I was asked by someone earlier, do we see a controlling mind? But there's nearly always in a practice, somewhere on the line there is an organising mind, someone who, and it's often a person or 2 or 3 people that come together to really make it work, and everybody else in the practice sensible enough to follow the lead. If you've got an organising genius of that standard in your practice, good luck to you, and they're very useful if you can cultivate them. So, organisational leadership is always important. Keeping your basic safety intact is very important. Really strong practices tend to know what they are doing in terms of the data underpinning their performance and their measurement of performance. They know exactly what they're doing in terms of clinical effectiveness. It might be in terms of how their referral rate to orthopaedics compares to their colleague down the road. But they tend to have a good idea of what they're doing, how they're achieving, and what the local standards are like. So they understand their data and their function. The other key place outstanding practices really score is in responsiveness. They understand their population, what that population needs, and they direct their services to the particular population they're dealing with. And in fact, and when John was talking earlier about someone in Manchester's got the student population they need to deal with, and we've seen some really strong student practices across the country which have done a really good job of adapting to a student population, which is slightly different to dealing with a all-comers, all-ages population of most general practices. We've seen some very strong homeless practices across the country, but these are niche practices which tackle a particular problem. We've also seen some very good all-comers general practices as well, so we have seen outstanding practices in all settings. So it's basically data and clinical effectiveness, responsiveness to your population, and adaptation to your own setting, and organisation and leadership. And those three tend to be really strong in the outstanding practices. So what have we got? We've got good access, good and effective leadership, and actually one of the best practices I ever went to was up in Winton in Cumbria, and what they really had was a degree of team coherence, which was wonderful to see. There are some general practices where the whole team you can just feel, if I came here, this team would hold me, would look after me, would manage me. If I was a doctor here, I would be fitted in nicely, but I'd have to adapt to their style, but it would be a good style to adapt into. If I was a patient there, or if it was my relative who was a patient there, I'd be delighted this team was looking after me, that kind of thing. Staff training support. An open culture is a part of good leadership. You're sharing views, you're taking in feedback, you're learning from feedback, and that might be clinical feedback in the form of audits and that type of more clinical effectiveness, or it might be patient feedback in the form of what the survey is telling you, what friends and family is telling you. But you will know all this, you'll have looked at it, and if it matters, you'll have done something about it. And if you just go, we've looked at it and it's fine, that's great. Outstanding practices tend to be plugged into local networks. One of our comments about a lot of our inadequate practices, at the bottom of the spectrum of the inadequate practices, in many cases one of the key symptoms of it is that the team in that practice will often be isolated from their neighbouring practices. They won't take part at the LMC, they're not at meetings like this, they're not at CCG education events, they're just themselves in their own little corner of a town. The outstanding practices are working with everybody, doing all sorts of things, showing collaborations and showing outcomes from their collaborations. Looking through, and I've said some of this as well, at the other end of the spectrum in the inadequates, what you find is they don't have a good culture around safety and learning from incidents. They'll tell us things like, no, there aren't any significant events around here. They don't do much in the way of quality improvement. They often have, dare I say, stuff which a good practice manager would look at and go, oh, surely they've done that. And we go in and go, oh dear, they haven't. And you can see all those various components. But I think the classic there is isolation and the loss of the leadership, the loss of their place in the bigger picture. These are specific trip falls under safety, and every top of the practice will trip up. Basically, they don't have the systems in place, and we pick up evidence of weaknesses down under these. In good and caring is actually a rather nice domain to assess. When I'm doing panels and getting reports in from various parts of the north of England, it's very rare that we find a practice that is completely okay. The practice may have problems, might not have got its safety systems in place, might not have got its clinical audits and clinical effectiveness very well done. But it's very rare you find a practice which actually doesn't care. Usually they care, but they may not be fully effective. So caring is actually a nice domain. There's a very small number where we get into that low level of caring. So most GPs, whatever standard they're working at, do actually care for patients, and we would also encourage that, obviously. Responsiveness. If I can give you, how many of you are happy with the idea of positive and negative deviation? You're happy with that idea? Fundamentally, for anything we look at in medicine, there will be some people who are right up at the top end of the distribution, and some folk at the bottom end, and most folk will be somewhere around the middle. And you'll have roughly a normal distribution. The very top end, who are for some reason excelling, are our positive deviation, and then we've got a negative deviation at the bottom end. And when we're talking about variation in general practice now, we tend to be talking in terms of a mean and above it and below it, positive and negative deviation. In responsiveness, think of variation not as variation in terms of variation in standards, but in terms of adaptation to the circumstances of the practice. This is where a GP will be able to tell you exactly, in my particular part of the country, in my particular part of town, it's like this, and what people need is, and I know this because, and I've measured this, and they will tell you how they've adapted their service to their particular part of the world. On the other hand, when we see practices which are less good, I will give you an example. I'm thinking of one here from the south of England, which was a practice in the university town, patient for students, but it was just running a practice in the same way it would run it for an all-age practice, which is the commonest one, and they hadn't really thought about how to manage their student population really well. So they came. So basically, in understanding adaptation, really thinking what do our patients need and how do we meet it. And well led. Here we go. We've got the well-led patient, so knowledge of the patient population, staff development and support, clinical governance, and dare I say it, a good practice manager is worth their weight in gold. Population groups, for those of you who, this is the other way of thinking about things, rather than going down the safe, effective, caring, responsive, well-led domains that we follow, we sometimes think about how do you meet the needs specifically of working age people? How do you meet the needs of people with long-term conditions? And these are just some of the examples under these headings. There are, of course, some practices which are niche themselves. There are practices specifically for the homeless, people with circumstances may make them vulnerable, that kind of thing. There are, but if you think about that, there are some practices which excel and are particularly good at one of these population groups. So, what would we say? This is the challenge. Primary care quality is actually pretty high at the moment, and despite the stresses it's under, and what John Rouse is organising in terms of that staff resilience and support teams, I think is very important. Because all practices, even if they're functioning well now, a lot of practices are vulnerable to the senior partner retires, the partner goes to Australia, the practice, you can't get a decent practice manager. All practices are vulnerable to loss of one key staff member. I don't think the bigger ones probably have a bit more resilience, but there is a lot of practices which are vulnerable to one key staff member going. What would we love to see? Strong governance and visible leadership in terms of actual standard of clinical services and an organisation of those. A culture that really looks at safety incidents and a culture of learning from experience, It's not that bad things don't happen in general practice. Every so often there will be significant events, incidents. We all have a few of them. But the question is, does the organisation take those and turn them into learning? Or does it just leave them as GP stress sitting in an individual GP who's worried about something? Improve the consistency of quality improvement activity, and the observation I'll give you here from what I've seen at panels. If I asked you about clinical improvement in your practice, you'll probably give me a very good narrative account of it. What you won't necessarily have, some of you will, some of you won't, you won't necessarily have exact numbers. So you won't be able to say the size of the problem I was dealing with before was, we put this structure in place, this process, so the outcome was. And when you've got those very conscious descriptions of what the problem was, structure, process, outcome, change made, it's very, if you can show a sequence like that, it's very difficult for us to say you're anything less than outstanding. So if you can describe your changes in terms of numbers and previous problem, your evidence is stronger. If you give us a verbal account saying what you've done, we'll accept that, but you'll get a good evidence. And these are the others. Again, it's the same challenge as John Rance was talking earlier. It's going to be the integration of working together at scale, supporting each other in terms of quality of medicine, quality of service provision. And then you've also got the medicines optimization. Support for poorly performing practices. This is actually very important. When CQC, we say that we hold the mirror up to the provider, and to some extent tonight we're doing it, we're holding it up to the speciality. Where the mirror reveals something that isn't nice to look at, we do need to make a diagnosis that there is a problem here. But it's then the question, does the system come around the practice to go, okay, you've got a problem, now let's help you out. And this is where the CCGs are important, NHS area teams are important, the Royal College of GPs providing some peer support and mentoring, and that can be a good practice for many practices. And local LMCs and CCGs are very important in this as well. And I suspect if you're on CSEC, I'm going to get a lot of LMC senior officers here, aren't they? And you probably help practices out with this kind of stuff. The key thing is that it's not that inspection is not an end in itself. It's more like a CT scan result. It goes, we've had a look at this place, there's a problem, and then the team needs to come around to support and improve. Helpful resources for practices. This is a standard, this is a classic list of CQC references. If you ever want to know what the CQC says on anything, it's very easy to go. The quickest way to find anything on the CQC website is to use Google rather than the internal search engine. If you just put in CQC report on CQC primary care, it goes more or less to the key pages straight off. Within that, we have got the provider handbook, which describes our criteria and describes lots of things about what we're looking for. And I hope most of you seen that book, or you know where to find it, either a physical copy or the web version. Nigel Sparrow's Mythbusters. Every so often there is a rumour goes around the healthcare system that CQC says you must do this week. Most times it's been slightly invented. CQC very rarely gives anything that specific that says you must or mustn't. We will say things like under the regulations you should know how you are managing infection control in your practice. It's very unlikely we would say specifically what you have to do. So our regulations give us scope, but nearly operating with positive intention behind the regulation, and not able to stand on one arm rather than the other, or do a cartwheel to the right rather than to the left. You gave me a great example of that earlier, didn't you? Yeah. We have an outstanding practice web toolkit, which gives you lots of examples of outstanding practice, and what to expect from an inspection and case studies, which we hope help you. Although most people have been inspected now, so hopefully you didn't find it, I don't know, did you find it okay or not too? Yeah, it's mostly okay. And then you've got the GP provider link, where most of these things are found underneath it. And then please will you help with my responding to our consultation. because our next round of inspections is going to be very different. We've been on a, I would say from a CQC viewpoint, we've done something like, I think it's about 8,000 inspections of English general practices across the country in about 2 years, which has been a huge undertaking just in terms of our logistics. We have actually completed that now, which we're quite pleased about, and we should get all the reports out by the end of March. The next phase of inspection, well, you've been asking me, haven't you, about this earlier, and anticipated the question, which is, what exactly is going to be the entity that we're going to be inspecting in the future, and that's not entirely clear just yet. Defining a GP practice, a care home, a hospital is actually, to be honest, they're all nice finite bodies. When it becomes a collaboration of about 5 to 10 of these organisations under one banner, quite what the registered entity will be, we're not sure. And we're going to be having, in fact Manchester's going to be one of the places where there will be probably some, to be honest, we're going to have to be in very good communication with you, because the provider landscape can alter so rapidly. We may have to be very nimble in terms of how we regulate. It may be time. That is our next phase consultation. If you've got time and energy to respond to it, yes, please put your input in sooner than later. Oh, we're a bit late already, aren't we?
I think we're right.
Yes, no, we'll be a bit late.
Yeah.
Okay. We'll have to take questions.
Thank you very much. Thanks.
Any questions?
Is it a standard? You work to the same standard in every practice, or you have set standards for certain practices in different parts of the country?
No, we work to a national standard. So if we find that something is normal for Manchester, no, there's no normal for Manchester, normal for Leeds, normal for Birmingham, it's a national standard we're applying. So that sometimes has given us lots of outstanding practices, because there's been an initiative within an area, and they're all doing the same good thing. Now, it may not come from the practice, it might be a CCG initiative, but all the practices have done really well on that. But no, we're applying a national standard as far as we can.
So there's a
The
separate
method and the sort of key lines of inquiry
So
will
there's
be
a separate
committee
methodology for each practice that you go in. It's the same. My practice, you come to me, it's the same. Your practice, her practice.
Yes.
It's exactly the same inspection.
Yes. Yeah. It's the same method under each one of them.
I have a question. You mentioned there was 9,000 primary care providers,
Yes.
and that's increasing because of federation clusters. Will we see that decreasing by, so say we've got 5 practices working together, and we're going to do 5 CQC reports and paperwork for that, and then another one for the cluster and another one for the federation, or will we just have one paperwork for the cluster or federation?
That's go on, yeah.
Just, okay, so there's a lot of work going on at the moment, and people spoke about consultation. So under the legal requirements, if you have an entity that is providing a regulated activity, then that entity needs to register. So we're very conscious there's flux in the system, clearly. So if you're a GP practice and you're providing essential medical services under a GMS or PMS contract, that is clearly a regulated activity. You need to be registered in your own right. If you then stepped into another entity which took on a different set of regulated activities, for example, an extended access service or a care home service that you were delivering as a legal entity, then the corporate governance of that entity, that would require that you would then need to register that. So it may be that we might see over the next few years, we might see the numbers of registered entities in primary care might go up. If we get mergers, if we get partners, groups of practices that decide, like Birmingham, we're all going to be one great big partnership now, thanks very much, we're not going to exist as individual partnerships. They will register as one entity because they've got one corporate governance, they are one entity. So you're seeing a lot of hybrid at the moment where groups of practices have perhaps taken one step towards collaboration in a cluster, but they're still individual practice entities and they might be doing other stuff as a collective. Do you see what I mean? So there is going to be change, and we're going to need to, as Peter said, we're going to need to be working very closely with providers. On the technical side, our registration colleagues have developed a taxonomy, which is huge. If you are a this and you are providing a that, then you need to register in this way, for example. But more and more, I think if you've got a very large partnership, we'll end up looking at the corporate bit, looking at the well-led, looking at the corporate governance of the entity, and then sampling insights. We've already said in our first consultation, we've gone through this round of inspection. In the next round, good practices and outstanding practices, we won't be going back every year. It'll be less often, the cycle there. And a lot more of our emphasis is going to need to go towards the new and emerging types of organisation that we've heard about tonight. So, it is a complex environment out there, and we're going to have to be agile and flex to adapt to it going forward.
Can I ask a question? That's related to this slide over here, I think, because given that we're a greater management group, what struck me about this was that it appears as though those areas that are more affluent seem to do better in the CQC assessments than those that didn't. Can either of you give us some confidence that this isn't going to worsen? Because the data is people look at this and think, as GPs, if I'm going to be regulated in the future, I'd rather go and work in areas more affluent. It could actually make things worse.
Yeah, it's not as straightforward as you may know. If you know these areas and you understand the differences within the areas and the difference in super output areas, the difference between individual practice lists, it really isn't that straightforward. There is not that linear relationship. Earlier in the year, in October I think it was, we were invited to present at an event where we heard about practices that were delivering in areas of substantial economic and social deprivation. And we did a correlation to that, which I'm happy to share. And you might expect there was that linear sort of correlation where a practice providing in this very economically deprived area has more challenge and is not providing as well. That was not what we found. In fact, nationally, some of the best practice, some of the outstanding practice that we've found is in areas of significant challenge. I spent many years working in Salford, and I've spent many years working in places like Liverpool, where I've found, especially with things like social entrepreneurship, social prescribing, there are a very dedicated group of people out there that are providing in these areas. So what we do have now, which is the key thing, is we have data on that sort of thing, so we can make correlations and we can find learning points in that, but it isn't quite as linear as that.
Yeah, and in fact I can give you examples from practice we've seen where we have seen practices which I think this ought to be a nice, and you don't have a classic GP training cliche of training practice and leaky suburb. Some of those have turned up and haven't been anywhere near what you would expect. And then we have been to some very rough places and found absolute gems. So we have found outstanding in all sorts of places, both nice areas, poorer areas, in all sorts of different places. There are, to be honest, one of the best things if you are looking at delivering care in poorer places, in the poorer, and you've got your city and haven't you? Is have a look at some of the very strong outstanding practices from the poorer bits of the country, because there's inspiration in that.
Well, we're going to have one tonight, so.
Yes.
Any final questions?
I have a quick question. In relation to your question earlier about standardised quality throughout the whole country, it's well known that certain areas of the country get better funding per person than others. I think Manchester's probably one of the worst, actually, isn't it, compared to, say, East Anglia. So better funding usually allows you to have better services and whatnot. So does the CQC take that into account, and how does that marry up in terms of the variation in funding, which is a key factor?
Absolutely. And one of the things out in this phase of consultation is to how can we incorporate that and overlay that. So, you know, there's already been, we contribute nationally to the conversation that goes on through the National Quality Board. This is it's well recognised, that variation is there, isn't it, right across the country in terms of general practice funding. So we can correlate that, you know, and if that's something that people feel needs to be woven into reports in context, please sort of feed that back. In the event we had a few weeks ago where a number of colleagues from Greater Manchester did attend, that point was brought to the table very, sort of very point well made really, that it's relatively straightforward for us to correlate that, because as an independent voice we're just, you know, we're noticing that, and you know, just as we would look at how many GPs have we got, and you know, our areas struggling to recruit, that kind of thing, it's another factor, so I think it is important.
Okay.
Sorry, just briefly, can I ask you with that data, is that established after the first visit, or is it after the revisits in practices that did need revisiting?
Okay. That is based on all the published reports as of December just gone. We have updated that a little bit, we refresh it every month. So if a practice has been, once the report is published, say you had a report 6 months ago and you might have been requires improvement in an area, 6 months later we come back and it's good, then that becomes the recent report on file, and that's the one that takes precedence. So the old one disappears off the system, and that's what's in the data then.
So it's a snapshot of the
data. It's a snapshot in time. Yeah.
Thank you very much. I mean, I'd like to think that this is the start of a conversation, because I know that over the next few years we are going to need to work a lot more closely. As you mentioned, there's a number of LMC officers here. So thank you very much.
We're definitely listening. Thank you.
Can I just ask, when is the you report at CQC? When are you able to get that working again? Apparently you're in emergency measures at the moment because of staff shortages, you can't answer your telephones. And you're
Sorry,
not
I didn't quite catch that. Sorry.
I rang up last week and I had to put an inquiry in. I'm still waiting for the inquiry to be answered. But on your telephone message that you're giving, it's if you've got an emergency problem at the moment, you can only deal with emergency situations as you've got staff shortages and sickness. When do you think you're going to get that sorted? Because I
think your plan probably is sorted. So if you have a general inquiry, that would, if you go for the general number, and that inquiry goes through to the call centre.
No, it wasn't answering.
No.
Oh,
okay.
I
don't know.
I'm sorry about that.
Come and have a chat with us, and we'll investigate for you. I wasn't aware of any local issue like that.
Right.
The O3.
Yeah, so that's the call centre.
Please put it on an email to inquiries. You can do that, and that's a such.
Maybe we'll take that offline.
Come and see me afterwards and give me the details, and I'll investigate it for you.